Right, so I was getting confused about the order, but I'm here and the slides are here. So, cementless total knee, are we reinventing the wheel? So I think if we're going to try and answer that question, what does it actually mean? Are we attempting to duplicate, and the impression is usually with inferior results, something that's already been created and optimized before? And so I think with knee replacements, we need to know whether what we've got now is optimized, and then could uncemented improve that? So this is a study from the Australian registry, and essentially they've taken a number of things like cementation or fixation, stability, bearing, poly, and they've said for all of those categories, which is the better and which is the worst, and then they've put it all together and said if you've got all the good things, that's an optimum construct, and if you don't have that, it's the other. And essentially what they've shown is that there's a substantial difference in revision rate if you have the optimum prosthesis construct. And essentially the optimum prosthesis construct in this registry study of almost 500,000 knees is cemented. So actually we've got it pretty good just with cemented the way we have it now. Part of the issue though is if we look at the registry data for both total and unis, we can see that as you go younger and younger, the revision rate goes up and up. So there is a group of patients where maybe we're not getting it quite as good as we'd like. And the question then is, could uncemented help with that? And we also see that if you look at this Finnish registry, that when you drop to the under 40, and to be honest, the number of people under 40 having knee replacements in Finland is very small, but their survivorship drops into the 80% at 10 years. So there's certainly some element around younger patients that we're not doing a great job for our patients, but for most of our arthroplasty, we seem to be doing all right with cemented. So this also from the New Zealand registry, over 96,000 knees, and they also broke it up by fully cemented, hybrid, and uncemented, because quite a few people have tried cementing the tibia but uncemented femur, because historically the tibia was the weak bit of uncemented constructs. And essentially, on all the metrics they looked at, the 10-year survivorship, the revision rate per 100 component years, cemented was better than hybrid, which was better than uncemented. So at the moment, uncemented's having a hard job showing us it's any better. So in this one here, essentially, a lot of papers are coming out which are optimistic about what might happen with uncemented, but at the moment the evidence really isn't there. So this paper has said that although it's been bad in the past, because of the changing demographic, we're starting to look at it again. And there certainly are some papers now with RSA studies showing that the uncementeds tend to subside a little in the first 6 months, a year. But then, having said that they do subside, they've then concluded that this pattern of subsidence we regard as being beneficial. So it's a bit difficult because obviously they're trying to support the fact that the implant does nicely. If we look at this one here, overall on the KSS score, uncemented did better. But if you looked at all the outcome scores together, cemented did better. So actually very little difference. And actually, interestingly, with this one, in the under 65-year-old age group, there was no difference. So the other thing to consider, I've just put at the bottom there, is the constraint in the implant, because a lot of the studies that have done well with uncemented have had relatively low constraint options. So CR knees rather than PS, mobile bearing rather than fixed bearing. And so we see this in a number of articles now that even though the evidence is not really there for uncemented, we're seeing a lot of enthusiasm and optimism. So we always have to be a little bit cautious as to why there's suddenly all this enthusiasm, and some of it is linked with companies and developments and that sort of thing. So this article in the BJO is quite interesting. Even if you read the abstract, they say it's higher revision rates, yet to show any benefit, but then it concludes with a positive, it's optimistic that it might improve things. They also say that it might be cost effective if, and it's a really big in capitals if, it leads to increased efficiency, and if you factor in revision rates. So some of the modeling about cost effectiveness, they've modeled that if we can reduce the revision rate by 10%, then it's cost effective. At the moment, there's no evidence that changing the revision rate is going to happen. But one of the interesting things, even in this article, they said that uncemented improves the results of unis. So that's not wrong if you look at the Oxford uni. So with the Oxford uni, when they went from a single peg cemented, which has almost a 12% revision rate at 10 years, and you go to the uncemented twin peg Oxford, that's down to 5.95% at 10 years. So with that particular model, uncemented has improved their revision rate. But on exactly the same registry, the results for the Zook, 5.79% at 10 years. So uncemented across unis doesn't show evidence that it's better, but within the Oxford, when they moved from cemented to uncemented, it did substantially improve their results. If we go and look at another way of looking at it, which is the ODEP ratings, where we rate all the implant constructs, and this is just for one particular family of implants with Zimmer. But here you can see with or without the patella, and whether it's CR or PS, a lot of 15A star implants. And then they have got a 15A star rating for one which was hybrid, so an uncemented femur. If you look at some of the other ODEP ratings, if you then go to the original LCS that then became the Sigma rotating platform designs, then they've been able to do a successful uncemented with the mobile bearing combination, but without using a patella. If you go to the Stryker one, that does have a 10A star, but interestingly, it's with an all-plastic patella. So you have to ask, if you're trying to save money by not using cement, but then you have to make one packet of cement to cement the patella, is that helping you with the efficiency? And then when you go to their latest version, which is with the metal-backed patella, then that's the one that they're struggling to get quite the same ratings. And some of that is because it's relatively new. But I think a lot of it comes down to this. So the implant is often about double the price. And yes, you can definitely save some money by saving on 1 or 2 packets of cement. All the other savings are assumed savings. And certainly in my private hospital, it might help a bit. In the NHS, if I can save 10 minutes, 15 minutes on a knee replacement, it doesn't mean I do an extra knee every day. It just means your knee just has a longer coffee break. So you have to weigh up what that's actually going to do for your practice. So essentially, the vast majority of knees are cemented, and they do well. Newer technologies will probably improve the outcome for cementeds, but already there are some good examples of it. It's probably only worth trying to do it for those young at-risk patients where there might be some benefit, but maybe not proven. But there is an increased risk of fracture, for example. And I think one of the things we have to be really careful about is the patella, because I went through the generation of us having a metal-backed, uncemented patella with one version we did 20 years ago. And if you have to take that out for infection, or if the patella button wears, it's really difficult to get that out without fracturing the patella. So with uncemented, there are many drivers for this new trend. Some of it is from the implant companies who want to make a bit more money, but it's not unreasonable to try and improve things for the very young active patient. For most cases, cemented is proven and better and cheaper. You need to consider the effect of the constraint that you're using. You need to consider if the savings are actually going to be savings for you, and then you might need to make a call as to what you're going to do with the patella, because there's not a lot of point in uncementing it and then cementing on a patella. Thank you.
Brilliant. Excellent talk, Andrew. That was really good.